This conference will now be recorded.
So before we get started with the group, and I hope this doesn't scare you three new guys away, but we lost one of our very dear members very recently, Herb Geller, and we we all know Herb because he also moderated a group, and he was also one of what Rick calls our brains trust. He always had information for us because he was a scientist and helped us with a lot of technical questions. And those of us who know him very well are very sad about this. And I'm going to start the discussion today with a few moments of silence for Herb, and then we're going to have a little open discussion, and then I can pick up on the regular group. So let's just be silent for Herb for a bit, and I'll pick up again in about a half a minute. Thank you very much. Would anybody like to say anything about Herb?
John,
Yes. Hi,
I'm
Jerry.
just, if I can, I'm just going to post in the chat the link to where the funeral is tomorrow, which will be live streamed, so anyone
Okay.
can watch.
Good.
Okay. Rather than post that link, let us post the link that we just sent out that has all the information, the obituaries, the information on the funeral, and everything else,
Oh,
so
great,
that we don't confuse people. Okay.
great.
I'll do that momentarily. I'm just trying to get some information. So please go ahead. Anybody who would care to remember anything about Herb. I mean, I'm sitting here thinking about his twinkly eyes. Which always got me. And once once I post this little link for you guys, and you will all have received it in your email that Alexa I put together with Alexa late this afternoon. There are some pictures in there that I know are going to make you smile. So I'll put that in. I'll put that in for you right now. But I know there's a few people who have thoughts here. I just hope that you can. Len, I see you have something. I'll hand it back to you, John.
Go ahead, Len.
Yeah, thanks, Rick. I'll be very brief. We all know about Herb's scientific expertise, his hard work, and all the things that he's done for ANCAN, serving on the board, doing the posters, critical member of the Brains Trust. I just want to focus more on Herb, the person, because I always felt that it was so easy to speak with Herb, and that I knew whatever information I was getting from him was completely honest and sincere. And I just love the guy. I have absolutely nothing negative I could possibly think of about Herb. And like the rest of us, I'm still kind of in shock that this all happened so quickly. And I just want to say, Herb, thank you for the gift of your life. That's it.
Amen.
Thank you.
I guess I would say just a couple things also, pretty much along the same lines. I have no medical background, no scientific background. I had absolutely no, he was not a peer in any kind of a way with Herb. But Herb welcomed me into his home. He came to see my band play. He talked to me about all kinds of things related and not related to our disease. Um, he was, I, I'll never forget him because he was one of those guys that he just did not, he just, he bore no attitude that I could see that was negative about anyone or anything. Um, he just was, like Len said, a really, really good and easy guy to talk to, and so full of experience and information, and a real joy to be around. And I feel also like it happened suddenly, even though it actually didn't. And it's not easy, as we know. That's all I can say right now.
Thanks, Jimmy.
What a lovely man he was.
Yeah. Yep.
Dr. John, do you have anything on your mind?
I appreciate the pictures of him that came in today on an email. I didn't even notice if it was from Rick or Alexa or who it was, but there's some really, really sweet pictures, and that sweet nature of his really shows in his pictures.
You know, that was the first fish he ever caught in his life. He must have been 76 when he caught that fish. He went on a real recovery, which some of you are familiar with. Some of you have been on it. It's a program for cancer survivors. It teaches them how to fly fish, I think. And it's a 2 or 3 day event. A bunch of guys here have been. And he was so proud of himself when he caught that fish. He couldn't get over it. You know, this Bronx boy finally caught a fish. But something else. For those of you who aren't familiar with the chat window, most of you are. There's two little squares on the top, and I just posted that emailing we just sent out, and with that picture of Herbie on real recovery.
I'll say something
Yeah.
about her.
Go ahead.
These days.
On my boating escapades, he'd see when I was on the boat, he could see in the background when I was cruising, and he couldn't wait after the call, after the ANCAN call, to get on where I was, where I was going, and all he wanted to do was talk about boating. And he loved sailing so much. He loved being on the water. And Len, he was so easy to talk to, and when he spoke to you, you felt like you were the only guy that really mattered because he was so interested in what I was doing. And we used to talk about how grateful we both were to be part of the ANCAN family. And he was just such a class, wonderful man. And I'm grateful to have had him in my life for the last couple of years. Thank you.
Thank you.
I was really impressed with Herb the last couple of months that even through rehabilitation and in the hospital, he always showed up for the ANCAN meetings and contributed. And it just was such a good testament to his stamina and his perseverance and dedication to ANCAN. And he's going to be greatly missed.
Harry Fish, I know you got something to say, man. I can see it. I can see the words coming out of your ears. So come on.
Yeah, I almost didn't want to come tonight, but I knew I had to. It's like I just felt terrible. That's all. What can I say? It was really, I don't know what to say exactly.
Okay, that's enough.
Yeah.
Times like this, sometimes it's very hard to put what you feel into words. Um, I think that the turnout and the presence for this meeting, just the fact that we can all sit here and appreciate Herbie is um, a huge tribute. We don't have to say too much. We know, and we all feel it. Most of us, certainly all of us who knew him. So thank you.
I'm just going to wait a half a minute here in case anyone else has anything.
Yeah, I'll say something. Herb is not known for years that this stupid disease, was going to get him, and in times when he was pretty fearful that his time was up, he didn't retreat. And some guys just retreat, but Herb would answer calls, let us talk to him and pep him up and let him know that keep on fighting, and he did it several times. He, he's he's a remarkable guy in that way. A good example of someone who could deal with handwriting on the wall in a very responsible, mature way, not not give in until it really was his time. So I respect that in him.
I appreciated what you said, Peter, about us being mirrors for each other also, even though it sent a little bit of a chill down my spine.
Yeah.
I will move on to the main body of the group. Before I do, I want for the tape to acknowledge that we have some corporate sponsors that have been helping us keep things rolling along here. They are Bayer, Pfizer, and Janssen, Myovant, Myriad, and Telix, and Foundation Medicine. Now, for you new guys, there are three of you, and we like, if we can, to spend a lot of time getting your story as best we can. We're especially interested not only in the medical facts, but what questions you have for us. And if you like it, we hope you'll come back and uh, and join us through your journey because we're all going through something very similar. So, for you guys that aren't new, there's a dozen of you that would like some time tonight. Um, I don't think I can be like Len, where he's as serene as a lotus blossom and finishes on time when he's got 50 people in the group. So I apologize ahead of time. I might be hurrying people along at some time or another, but we'll do the best we can. Um,
John, I don't need to be. I can drop off. Put me near the end, okay?
was that Joe?
Yeah, that's Joe Commander.
Okay, very good. Very good. Thank you. Okay, so Doug. Doug is
Yeah.
a new guy. I've lost your picture, but I've still got you here. Are you still at your computer?
I'm still here. Yes, I am. Unfortunately, I have another meeting in half an hour, so I don't know how long this group usually meets for.
We meet for 2 hours, but let me try to keep you for about 15 minutes and just get your story, at least if you think you might be interested in coming back someday, okay?
Sure. Yeah.
How old are you, Doug?
I'm 82.
And where do you live?
I live in Burlington, Ontario, which is near Toronto.
Okay. When were you first diagnosed with prostate cancer,
I
Doug?
was diagnosed in 2005 when my PSA was 5.2.
2005. So you have 18 years
Yes.
with prostate cancer.
Yes.
Well, that is wonderful to hear. I hope that happens to all of us. When
Well,
you
if it,
got first, yeah,
sorry.
you'll have to tell us your secret sometime. When you were first diagnosed, could you tell us a little bit about your diagnosis, such as what your Gleason score was? Did you have any metastases? What your
No. Yeah, my Gleason
no?
score was 6. And after I spent a few months trying to decide whether to have brachytherapy, radiation, or surgery, and I chose the radical prostatectomy, where everything, lymph nodes, seminal vesicles, everything were removed, and my surgeon said the margins were clear, and as far as he was concerned, I was cured. He was surprised at the 6 month post op when my PSA was 0.08. He felt it should be 0. So he checked it again every 6 months, and it has slowly, very slowly risen. Like the doubling time is something like 2.5 years. And I've had 2 or 3 opinions from urologists. Early on, I was told that I could be a candidate for salvage radiation. When I talked to a couple of patients who had had this and were having tremendous problems with urethral strictures and rectal bleeding, I chose not to have that. But one urologist said that when my PSA got to point 0.2, he would recommend either trying salvage radiation or hormonal treatment.
Mm-hmm.
And when it got to point 0.2, we decided that we would continue to monitor it. And the most recent PSA was 2 months ago, and it was 1.2. Last year, I had a PSMA PET scan, which didn't show, it didn't light up anywhere in the pelvic bed or lymph nodes or bone anywhere. And I have no symptoms in bones. But I saw 2 urologists in the past month who both felt that I had a very slow growing metastatic prostate cancer, although they weren't able to identify the metastases on images. They saw no other reason why my PSA should be continuing to climb slowly.
Yeah.
one of them said, "Well, let's keep an eye on it every 6 months, and when it gets to 6, let's do something." So that's where I am now.
Ah, yes, it does sound like you have a very nice, lazy, slow disease process going on, but didn't get cured as you had hoped at first.
Hmm.
Did any of these urologists ever do any genetic testing?
No, no, they didn't, and they never discussed it, never offered it, and I'm not sure if that would have been helpful in the decision making around treatment.
Sometimes very early on, guys like you get special tests which help predict who's going to recur and who's not going to recur. So I thought maybe they might have tried something like that with you. Do you have a family history of prostate cancer?
No, I don't. And my father died young, 70, of a hemorrhagic stroke. I have 2 brothers. One died in his 40s of a heart attack, and my other brother died 2 years ago of melanoma, but no prostate cancer.
Okay. And after you had your surgery, did your PSA go down to zero for a few months and then pop? Or
It was never zero. No,
never
it
got all the
was
way down there?
no, it was 0.08, and
Mm-hmm.
it just very, very slowly went up from there. Very slowly. In fact, one time it actually went down. I remember when it was at 0.83, and then 6 months later it went to 0.82. So um, if doubling time means anything, and one of the urologists says that that's a signal for him, uh,
Yeah.
that would suggest that it's so slow that maybe I won't die of it, but I probably have micrometastases somewhere.
Did you come to our group because you're still uncertain about whether to have treatment or not, or what brought you to us at this time?
The reason I came to the group was because for the first time the word metastases was used,
Hmm.
and I didn't like that. And it's I guess it's the only explanation that they can give. I try to explain it away as maybe these are normal prostate cells that produce PSA. And I think early on, that was a suggestion that the original surgeon, who is now retired, also wondered about because it was so slowly rising.
So, Dr. John, I'd like to just jump in, and I'd like to bring Dr. Jack in because there's a great similarity between the two stories, and I think that Doug and Dr. Jack, who are somewhat contemporaries, I think you're a little bit junior, but not very much, Dr. Jack, and you might just want to give Doug the benefit of your wisdom.
Well, your story sounds very similar. 20 years ago, I had my surgery, and it was I was a 3-4 rather than a 3-3 like you are. And I had clean margins, clean seminal vesicles, no lymph nodes, good prognosis. He said, chances are, you're not going to have a reoccurrence. When I was 15 years out, he said your odds of having a recurrence around 3 to 4%. Well, wouldn't you know, I reoccurred 5 years ago, slowly creeping up from 0.06 detectability. Currently, my latest PSA was 2.01. So I had lots of scans, lots and lots of scans. I had a colon scan 5 years ago at Mayo. I had a PSMA scan 2 years ago when it first came out at Sloan Kettering. I had a PSMA scan done earlier last year. All negative. Everything's been negative up until my latest PSMA scan, and that showed 3 lesions in my right lung, lymph node involvement, and 2 in my bones, and 1 in my rib, 1 in my L5 vertebrae. PSMA avid I am. For a while, everybody was wondering if I had any avidity at all. So it was obviously correlated with the level of my PSA, because as the PSA got higher, my PSMA became more avid. Currently, the recommendation is for me to go through ADT, complicated somewhat with atrial fibrillation, and I cannot take the primary Relugolix, Lupron, or the Garelix, or one of those major androgen depletion drugs. So I'm taking a secondary one that just knocks out the receptor sites. I'm taking darolutamide, and and I may
Jack,
get
do you want to share your age with Doug?
my age, right? Well, I'm going to be 84 August 12th. So
Okay, so
we're, I guess, in the same.
you are. And so, Doug, is there anything you would like to ask a peer who has very similar considerations to you?
Yeah, that's very interesting. Because when I had the PSMA, my first one, I think it's been 2 years. And when I asked the urologist last month if he'd like to order another one, um, I was surprised at his answer because he said, I think I would rather just monitor because it's slow growing. On his calculation, I think it came out to 3.1 years, the doubling time. And so he felt at my age, with that doubling time, I'm going to be, I guess, your age or a little older when it gets to when metastases were found in yours. If you look back on yours, do you wish you had done some treatment earlier on?
Sure. I wish I had done some treatment earlier on, except we didn't know where to treat because there
Yeah.
was nothing visible. And there was one school of thought that said, let's find out where it's located before we treat it with either radiation or hormones. And the other school of thought, Sloan Kettering, said, let's assume it's there. I guess they were very aware of the micrometastatic aspect of it. And let's go for it 5 years ago. And let's see if we can put it back to sleep with ADT. In retrospect, if I knew as much as I know right now, I would have gone with some early ADT and try to just put it back to sleep so it wouldn't get as large as it has gotten to the point where it's showing up in so many spots. And I don't know if it still would have shown up, but I'm assuming the ADT would have made it more dormant and perhaps could have given me a little more peace of mind than I have right now.
So when did the atrial fibrillation start?
About 3 months ago, when I was getting so anxious about what could be going on with me. And I had an ablation 10 years ago and it was very successful. But I got quite anxious about, what's going on. And I can't tell whether it's just a reoccurrence of atrial fib that can occur after you've been ablated or whether it's my level of anxiety that promoted the atrial fib. So I'll never know that for sure.
And you don't drink wine?
I don't drink anything. It's a good question. No.
Yeah. Um, would Lupron have been a choice of treatment for you 5 years ago?
5 years ago, they didn't have Relugolix or Orgovyx. I would have probably said yes. And right now, I'm more inclined to go with the Relugolix, especially with the atrial fib, because the heart's a bit too vulnerable for me to feel comfortable with
Mm,
Lupron.
mhm.
Jack, I would
That's
say to you, this is Alan. I would say to you, I also have lung nodules, and I was treated last year at Sloan with a ADT. I'm younger than you, 69, and I had the Lupron along with Xtandi. And I will tell you that after 6 months, a CAT scan couldn't find the nodules. They weren't that big to begin with. And while they're still there, they're probably very, very tiny and not picked up on a scan. And so, you might do that scan if you haven't at some point, but I think that my guess is you'll get a very good response even with darolutamide alone.
Did you do the PSMA as well?
I did it to detect those nodules, and I had multiple PSMA scans that didn't show much, although in hindsight they were very, very tiny. But my PSA when I started that was only 0.5. And so it wasn't until my PSA got up to about almost 5 that they were detected, and that's when I started treatment.
Did they do any SBRT on you?
I
Any
had
radi-
I had salvage radiation prior to all this business with the lung nodules. I had that about 3 years after my prostatectomy in 2016, and my doubling time was rather low, roughly 18 months, and it took almost 6 years for me to need treatment.
What was your
So
PSA when the salvage radiation was done?
0.2, no, sorry, 0.1.
Oh, yeah.
Yeah, I acted pretty quick because that was the wisdom back in 2016. I
Yes.
did do an MRI though, to be sure that there were nothing visible that would help, inform the salvage radiation. Maybe there was a large lymph node, didn't show anything. And all the PSMA scans that I had um, did not show anything in the prostate bed. So those lung nodules either were present at a very tiny level before I had surgery, or maybe at some point even before I had radiation. Um, and so I'll never know. And but I'm grateful that at least right now, 3 months post treatment, PSA still remains undetectable.
If
Doug, I know you have to go soon, and so do we. I want to welcome you to group. Suggest maybe you consider consulting with a prostate specialist oncologist to add to the opinions of your urologists, and uh, come back someday. We meet every week, and if you could, before you go, maybe put your phone number and your email address in our chat window.
Okay, sure. I guess I just wanted to ask a question.
Yeah, yeah.
If the PSMA PET scan showed something in the prostate bed, would either of you consider having the radiation, say SBRT, to that area?
Well, the issue I think here is the SBRT alone going to treat it? The answer is probably yes. I think most of us, if we were in the situation, everybody has to answer themselves. We can't give you medical advice, Doug. But I think most people, if they saw lesions in the prostate bed, would radiate them. However, the problem is the micrometastasis that you cannot see. And
Hmm.
what we find is that when men just go with radiation and they don't accompany it with hormone therapy of some type or the other, it's more likely to come back because it isn't systemic and you need some sort of systemic treatment. So it's very tough in Canada. We've got not many, but enough Canadians to understand. It's hard to get to a decent oncologist, although where you are in Burlington, there are some some genitourinary medical oncologists in Princess Margaret and Sunnybrook. But we strongly would suggest you talk with them. You have a tricky situation in that, should you intervene, shouldn't you intervene? I do think that at 1.2, if you're avid, you may well get a result, even though Dr. Jack didn't. You may, and so I think you've got to push to see where this is, and come on back and give us a report. And if you, the chat window are the two little boxes at the top, open it up and just, if you're not already on our database, just give us your email and we'll make sure that you get it on. It doesn't have to be public. You can just send it to one of the organizers. We'll make sure that you get on there.
Yeah, and thank you. Both of my urologists are willing to uh, recheck my PSA and see me in September, which is fine with me because I have a summer residence that we just opened up last weekend, and that I think waiting over the summer is no problem.
John Citizen, hi. Welcome to the group.
Well, thank you very much for letting me join the group. I'm very appreciative, and I think this is the group that I've been searching for because it brings some of the information that I've been talking about and dealing with to a little bit of higher level because of the people that are on the program today. Uh, I was diagnosed with prostate cancer on May 15th, 2017.
What
And I
age were
quickly
you, what age
decided to go ahead on. Sorry,
what age were
John,
you? What age?
I'm 72 years old.
72.
okay.
So you were diagnosed
Well, I was
6 years
diagnosed
ago.
at 67 years old.
Gotcha.
Yes. Um, and I chose to have, with the information, my PSA was at 12, so it wasn't all that high, but I had been watching it for the last 4 consecutive months, and I realized the PSA was rising, so I chose to have a biopsy done. The
Uh-huh.
biopsy showed that, yes, I did have 2 lesions on my prostate, and I chose to have a surgery. It wasn't a long, drawn out decision for me. I knew that my best bet was to go out and just have the surgery done
Went right
and
ahead.
John,
to eradicate.
if you would, let Dr. John ask you the questions because we have to move pretty quickly, and
Okay,
so
that's fine.
that way we can get the information out of you. We found this works a little better for us because, as you can see, we have a lot of people. Go ahead, Dr. John.
Okay, so we've got you getting diagnosed 6 years ago, having a PSA. Did you say 12 or something like that?
Yes,
And then you went right ahead and had your radical prostatectomy. Where do you live, by the way?
I live in the Houston area, Houston, Texas
Oh,
area.
oh, okay. We got some good docs down there. And then what happened after your prostatectomy? Did your PSA disappear, or did it recur rapidly, or what?
It never disappeared. The
Never.
PSA sort of lingered around uh, zero point 0.8, and from there it grew gradually. Uh, I spoke with my urologist, and he said that he thought he had got it all. With the word "thought" was
Yeah,
the
yeah,
main word.
yeah.
He was unsure.
He didn't quite get it. Oh, by the way, when they took your prostatectomy tissue to the lab, what did they then find out for your surgical pathology? What was your final Gleason score, for example,
Yes, my Gleason score was 7.5.
at the surgical time?
Yes, 7.5.
Now,
No.
7.5 sounds a little bit like a PSA. Are you sure?
No, I'm sorry. The Gleason score was 7.5. At the PSA level, it was at 12.
The Gleason score couldn't have been 7.5. It could have been a 3+4 or a 4+3, but there is no Gleason of 7.5, John.
Well,
It
Check
doesn't
it out.
exist.
Check it out for us, John. And if you come back
Yeah.
to group, let us know what it is, because
Yeah.
it's
I mean,
kind of important.
you may have, especially if it's a final one, because they slice it all up. So they'll give you a final pathology, and it's either going to be a 4+3 or a 3+4. I've never been in this game since 2007. I've never heard of a 7.5 Gleason.
oh, that's what I was told.
Okay. Okay.
And
Well,
even
Take a
check
I
it
look at
out.
your
consulted.
pathology report,
Okay,
and
I
and
will.
and 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 come back and tell us.
I consulted 3 doctors, not only the urologist, but the medical oncologist and a radiation oncologist. They
Yeah,
told me the
good.
same thing.
So did you go on then, because your PSA came up after your surgery, to have radiation or hormone treatment or anything?
Yes, I went on ahead and had radiation therapy, 39 treatments, consecutive treatments, and then they found out that the cancer was still there. So they went ahead and did 5 intensive treatments after that, 5 straight days.
Yeah.
And that seemed to arrest the cancer right there. The PSA did not grow any farther than that, and it started to decline. And then they started me on Lupron treatments. I went on Lupron for almost a year and a half.
Did they
Now,
not
And
start that Lupron before your treatment, John? Did they start it after your treatment, or they didn't start it ahead of time?
no, they did not.
Okay.
That's also very unusual. Most doctors putting you on Lupron will start you ahead of time to weaken the cells before you you do it, especially if they're doing 39. So again, just weird. But please
How's
go ahead.
your how's your PSA now, John?
0.
Oh, good. And is that a result of the radiation treatment, or did you are you still on Lupron or what?
No, I've been off of Lupron for the last 2 years. I think
Uh-huh.
it was the radiation treatment was what
Yeah,
finally put it to rest.
yeah. That can kill cancer cells. The Lupron can just kind of put them to sleep, as Rick or
Yes,
somebody said earlier, or Jack, I guess it was. So now you're running a non-detectable PSA and off of all treatment for 2 years.
yes.
Excellent, excellent. And so who is your main doctor right now?
I have two, my oncologist and my radiation oncologist.
What's the name of your oncologist, John?
Dr. Corey.
Corey? Do we know Dr. Corey, Rick? No?
Mm-mm. No.
Okay. Okay, very good. Did any of your doctors get genetic testing?
I don't think so.
They get a cheek swab or anything like that? Does that sound familiar?
No, they did not do that.
Are you a vet by any chance?
No, I'm not.
Okay, I only ask because we have a vets group as well. Tell us what questions you have for us and what you were looking for when you came to group.
Well, I was told that your group was I'm currently involved with another prostate cancer program in East Texas, which is a large
Uh-huh.
swath of the Texas area.
Mm-hmm.
And the partner that I am with, he told me that he was part of this group. And he said, you're going to learn more about prostate cancer if you were to get on board with this group here. So I'm just ready to learn more,
Good.
find out more about the treatments, and continue from that point.
Well, that's just what happened to me. At first, I could hardly follow the discussion. Then I started writing things down and looking them up, and pretty soon I could keep up.
Yes.
Does anybody in the group have any comments or questions for John?
Well, I'd just say, John, you're doing well. You're undetectable for 2 years. Um, as whoever told you that you'll learn a lot in this group was right. So you can just sit back, relax, attend the sessions, and learn. But
Thank you very
you don't
much. And
need
that's
any
what
advice from us right now.
okay, I intend to do
John,
so.
John, what facility in Houston are you using? Where are the doctors?
A Millennium Oncology.
Okay.
They're one of the largest private uh, owned facilities in the city. You have MD Anderson and all the others, and then you have the private, which is Millennium Oncology on the northeast, northwest side of the city.
Okay, just curious.
Good night. Thank you, everyone.
Who was that? Oh, that was Doug. Bye, Doug.
Yeah, sorry. Night.
Any other discussion for John? Well, we're very happy for how things are going, and we welcome you.
Thank you very much.
Um, Now, I have another guy who had some mixed feelings about whether to be introduced now or in the future, and that was Mark. Have you decided, Mark, what you want to do? Mark K?
I'm not sure if you guys are for me, but um, 14 months ago, they told me that I'm prostate cancer to the bone, stage 4. So a lot of those things you're talking about, they don't follow me at all. I want to find out somebody about that's got what I have.
The two
I
guys
want.
that you just heard about, Mark, are are very fortunate in that they have either very slow, indolent prostate cancer, or they have cancer that's in remission right at the present time. And the other 40 something guys in the group were listening to that with envy because they're more like your situation. So
Well, that's what I want.
there's plenty of people here who have bone metastases and stage 4 cancer, yes.
Okay, I guess I have to join the chat room then.
Well, if you want, I'll ask you those questions now, or I can.
Well, go ahead.
Uh, where are you located?
Phoenix, Arizona.
Do you go for your treatment in Phoenix?
Yes.
How old are you?
67.
And how long since you've been diagnosed?
About 14 months.
And how did it come about? Did you have a rising PSA or symptoms or what?
Oh yeah, my PSA was real bad. I retired and everything was going good. All my numbers were going down. And then, so I started complaining. I said, I got a new CPAP machine and boy, my shoulders and my neck were bad. They took an x-ray. They said, you're fine. Get a new mattress. And then I just couldn't exercise or anything. I was just miserable. And then they started doing tests and they said, yep, you've got prostate cancer.
The test was presumably a prostate biopsy?
No, they never biopsied. I don't have a Gleason or anything like that. That's just it. I didn't do any of that stuff. They just, I get shots and I take 25 pills a day and one of them's a vitamin. The rest are for cancer.
Oh, jeez.
Did you have any, is one of those pills at least one for prostate cancer then?
Well, I take aboout, right? 4 of those in the morning.
That's for
Abiraterone.
prostate cancer, yeah.
Yeah. And then I take, I get 2 shots tomorrow. I get Eligard and what's the other one?
Exgiva.
Exgiva, yeah. And then I take
Okay.
a lot of calcium and I take prednisone twice.
Okay.
Right.
What's
But a
your
lot
latest?
changed.
You
And
don't have any Gleason score to tell us at all?
they never took a biopsy of my prostate. My prostate's fine.
And it's still there. You didn't have it removed or anything, right?
No, I've never had surgery in my life. I was healthy 2 years ago. I
What's
can
your
barely get out of
PSA
bed.
level? What's
Huh?
your PSA level now?
What's it supposed to be?
It's supposed to be under 4, 3 or 4.
I don't know what that is.
Doesn't sound familiar.
No. He said I'm about as normal as I'm going to get, but I'm never going to get any better. And I'm 67. In the last 14 months, I've aged 20 years. I walk around like I'm 87 years old.
Well, how long have you been on those medicines you just told us about,
14
Eligard?
months. 14 months.
I mean, the medicines themselves can make you feel kind of old.
Oh, yeah, tell me about it. They got side effects like you wouldn't believe. That's what I want to talk to somebody about, not today, but oh
How
yeah.
about scans? Did they put you in any kind of a
I
scanner,
had a
a
full
PET
body
scanner?
scan. I had real problems with my hips. They took an x-ray, that was fine. I had a full body scan, that was fine. I had the one on my neck and my shoulders, that was fine. But I had radiation because I could barely get out of the bed. And the doctor there said it's diffuse, which to me means it's all over. But it helped because it had swollen around my organs so bad when I laid down I couldn't even barely breathe. Going to
But
bed was miserable.
Mark, how could it? I don't understand how he could have said it's diffuse without scanning you in some way. You said all your scans were fine.
They never gave me any numbers on it. They just
They just
described it as diffuse.
diffuse prostate cancer spread around, presumably. Is that what you mean?
Yes, spread around through my organs and around my
Okay.
big bones.
So one of your scans must have said that you had diffuse prostate cancer
That's
spread
what I'm
around.
saying, yeah.
Yeah, okay, I understand. Okay. So you still have your prostate, and you're still taking medications.
Oh, yeah.
Okay. How about genetic testing? Did they ever test you for any
No,
genes?
no, and that's just it. You know, I come from a very tight-knit family, but no, they never said anything about that.
You don't have any relatives with prostate or breast
Well,
cancer?
funny
Or...
enough, I've got a first cousin, my mother's older sister, her boy. He died last year of prostate cancer. I didn't even know he was sick.
Oh,
He was 72. I'm 67. He's 5 years older.
makes you wonder whether genetic tests might be worthwhile to see whether you guys share some sort of vulnerability.
Well, I don't have any children, so what's it matter? I asked
That's
them.
true.
I asked them if there's something like, sometimes they have special studies,
Yeah,
and they said, no, not for you.
meaning like joining a research project or something like that.
Oh, yeah, because I got the
Yeah,
time. I'm retired.
yeah, yeah.
Yeah.
Are you a veteran by any chance,
No.
Mark? Okay.
So
And
I'd
who's
like
the...
to say a couple of things. Mark, they can't. The doctors don't have the information that they need to tell you that there's nothing special for you. Now, that might be how they do their business, but it isn't how they're supposed to do their business because there are guidelines. A man like you is required to get genetic testing. Required. I mean, it is in the guidelines provided by the medical authorities, if you like, the medical associations, ASCO and NCCN. In addition, we should be checking to see not only if you have inherited mutations, but also if you are making any mutations yourself that will make you a good candidate for certain medicines. The problem is that a lot of these doctors use a formula. So they brought you in. I'm guessing you got radiation therapy. I don't know how many sessions of radiation they give you.
15 times on my spine.
Okay, so they gave you 15 times on your spine and they didn't radiate anywhere else?
No.
Okay. And over how long a period did they do those 15
Well,
radiation
one a
treatments?
day, but, weekends were off.
Right. So they did 3 sessions of 5, which again is a very strange pattern of radiation. Um, so I think what you got to do is push where are you getting treated?
Palo Verde cancer specialists in Phoenix.
Okay. I think that you've got to, are they associated with one of the hospitals or not?
Oh, everybody there is affiliated with all the hospitals, but they have what they call City of Hope, and they've got a Mayo Clinic here too.
Right. I live in Arizona. I'm pretty familiar.
Okay.
Um,
But the
so
thing of it is I could buy the abiraterone for cash instead of paying 1,600. That's bigger than my Social Security check.
Well, I'm sure it is, and there are ways and means, as people on this call will tell you, to get that abiraterone. The other thing is you don't have to be taking 4 pills a day. You can be taking 1 pill a day with a low-fat meal, which your doctors haven't talked to you about. That would save you a lot of money in your pocketbook. But there's a lot of issues, and my concern is you're not getting the right treatment from the right doctors. What's your insurance like?
Well, Medicare, and then I have Blue Cross Blue Shield of Arizona as my supplement.
Right. So that probably means What, can you get to Mayo or not? Are you covered at Mayo?
No, nobody. From my understanding, nobody is.
Well, we've got a number of men on this call who are. So, you know, we can open it up in a minute and have them talk to you. We've got one guy who I'm sure would be happy to speak to you, who lives here in Tucson and drives up to Mayo. We've got another gent who currently lives on the other side of the line, but he's moving back up to the Tucson area. They both go to Mayo. We've had a number of people who go to Mayo, and you can get covered. The problem that you're facing is this: prostate cancer is a very fast moving field.
Yeah.
And unless you have a doctor who specializes in prostate cancer, you are not going to get the best treatment. For example, I bet neither of your docs, either the radonc or the medical oncologist, are even aware you can take 250 milligrams a day with a low fat meal. But we've got guys on this call who are doing that. And when you don't have a lot of money, it can make a huge amount of difference to you.
I got a couple raised hands I'd like to go to, if that's okay, Rick.
Go ahead.
Peter?
Yeah, yeah. So oddly enough, I had dinner last night with a friend of mine who's pretty much in the same situation. He's been on a call once or twice, but the question came up of is it? I mean, and he's a Kaiser patient, so he's not getting great care either. Um, the question comes up of, does it make any sense for someone in that situation, or in John's situation, to biopsy the primary? Would it reveal any information that could be useful down the road? And I don't know if I have an answer for it yet, or whether we've really discussed that. So I'm just going to ask that.
Well, you know, it's a really good question. I think that what it would tell you was how aggressive Mark's disease was. I think
Right.
what is on the table for Mark, which his doctors haven't talked about him, is treating that primary. And you know, many of you here in this group who were diagnosed metastatic, de novo metastatic, just like Mark, have finished up having your primary treated, having the gland treated with radiation. That's why I was curious what they radiated. So again, the doctors who are treating Mark are unlikely to raise that because it's a nuance. If he was seeing a genitourinary medical oncologist, the chances are they'd be talking to him about radiating that primary, which of course would be covered by his Medicare. These are all things that are going to lengthen his life, and why we really want to get him to a specialist and not one of these general medical oncologists.
Well,
Right.
there's a place called City of Hope too. They seem really nice on the phone, but I have not gone there. No.
Well, here's the problem. Here's the problem with City of Hope and MD Anderson. These are all satellite facilities of very major hospitals. If you go to that hospital in Duarte, California, or in Houston, Texas, you're going to get really good care. The problem with these satellite facilities like you have in Phoenix is that the care isn't so good. The only really strong hospital, and it's an NCCN hospital, meaning it's probably one of the best 35 cancer hospitals in the country, and the only option you have there is Mayo. And we are really, really short of specialized prostate cancer doctors in the state of Arizona. Really short. And so you finish up having to figure out a way that you can get to Mayo or go out of system.
Well, I mean, it doesn't matter to me where I go, but what they told me is basically you're just going to orbit around where you are until something changes, and then depending on what changes, then we'll change the medication. So
yeah, but we'd like to say you're not going to orbit. We'd like to say that we can do a lot. There is a lot more that could be done for you. I mean, there's
Oh
activity
yeah,
I see
I'd like to be more
in the
active. I
chat
can't.
window.
I'm not active hardly at all. I mean, it turns out to be a punishment. So I got to
Okay.
get that straight.
Yeah, well, that's another thing that we don't have time to talk to you about today. But what we're saying is they're not treating you right, man. The guidelines for your disease are not being followed by your medical oncologist.
Mm.
And that's what we're telling you. You know, if they had to radiate up and down your spine, the likelihood is there were more than 5 spots in your body that they saw 14 months ago. And if there were more than 5 spots, they should have been talking to you about other treatments, possibly including chemotherapy. Maybe they did and you didn't want to do chemotherapy. I don't know. But they should have been talking to you about that. They should have been talking to you about, and then the abiraterone and the Eligard. That's good, but there was more that was needed. Now there are other treatments that are recommended for you, or may be recommended, but you're not getting the care you deserve. And if they keep treating you like this, you're right. You are going to orbit around until it gets worse. But come to this group, stick with us, get you to the right doctors, and I bet we can improve your life. Ask how
Good.
many guys on this call have found that out.
Okay.
Hey, two quick things. Abiraterone is generic now. I get it for $5 a month. My Kaiser pays about $2.50. You should look into getting the generic version. It doesn't cost as much as you're paying. Also, exercise. You've got to start exercising. That is how you get your energy back, get back those 5 or 6 years you lost. Every single day, you got to get outside and walk. Walk a mile twice a day. Start with doing other kinds of exercise. Get on a treadmill. Do weightlifting. Not heavy. Just do something. That is how all of us here have gotten away with the problem of fatigue and being tired all the time. Not all of us, but many of us, most of us. And it really gives you your energy back by doing the exercises.
I second this, Mark. Jeff, I second it wholeheartedly.
I'll chime in because exercise definitely helps. I was diagnosed stage 4 with metastatic about a year ago, and from my biopsy, they found some treatments that will be my future that without a biopsy you wouldn't have any idea is possible. Things like immunotherapy. You, even if you don't get a biopsy, they have what are called liquid biopsies, where they can find out about your cancer just from blood. You know, you got a lot of questions to be asking your doctor if you're going to stick with the same doctor or at least get a second opinion,
And
in my
maybe
opinion.
check out for us whether you really are blocked from the Mayo Clinic or not. Check it out for sure.
Let's just visit with Dennis Correa before we leave. Dennis, what did you find about on Medicare about accessing Mayo?
Maybe he left, huh?
How about, I see Jerry's there. Jerry, how about you about accessing Mayo?
Medicare doesn't care. My supplement pays for it. I have an NA and Medicare pays. Now, on the consumer side, the hospital side, they do not accept Medicare. But I have had absolutely no problem going into Mayo and getting everything paid for.
Do you have to submit those bills yourself then, Jerry?
Nope. Mayo takes care of it all.
So if Mayo takes care of it, then they do accept Medicare.
I think only for certain specialties. I don't know how they work it out, but I've got Medicare with United Healthcare Plan F as a supplement, and I have no problem. I was uh, before before it went generic. Um, I was paying like $800 a month for that. Of course, luckily I got a charity to pay for that. I mean, I don't know what the problem would be unless the supplemental insurance wouldn't help pay at Mayo.
Yeah, I mean, we know too many guys that are treated at Mayo with Medicare, Mark. So we do believe it's an option. Um, the rumor is they don't take it, but you have to find out which supplemental plans they do take, and maybe we can connect you. I don't know if there's anybody else here that's getting treated at Mayo, in Jacksonville, in Rochester, or in Phoenix. I don't think so. But anybody else gotten treatment at out of the Mayo facility?
Well, I didn't have treatment, but I had a total evaluation. I was scanned there. I had an MRI there. I had a consultation at Rochester 5 years ago. No problems with my Medicare and AARP supplement. I don't know if anything's changed in 5 years. They took care of everything. I didn't have to pay a penny.
Okay, thanks, Jack.
So the bottom line, Mark, is that we think that you can have uh, um, a more deep look at your diagnosis and a more deep and comprehensive treatment plan if we can get you to a prostate cancer specialist. And we'd like you to consider that. I also just have one other question, and then I'd like to move on to the other guys in the group, which is, do you have anybody that you live with, anyone to help you with all that long list of medications, transportation, any
No,
social or other?
no, I moved here. I retired. I moved here. I thought I would meet a nice girl, fall in love, and travel. So I'm
Instead, you
alone.
got prostate cancer. Okay. Okay. I'm gonna get to our guys, the
Thanks.
regulars. I have. You're welcome. I have about a dozen, and I'm gonna start with Alan Babcock.
So, John, I'm going to pass. I think there's probably guys with more pressing issues than I've got here. So, why don't you go on to the next person?
Okay, we'll circle around if we can. The next person is Pat. Pat, are you still? Oh, there you are. Yep.
Yeah, I just turned it on. I had some scans done last Friday and I got the report. I'll just read the impressions.
First of all, what kind of scan was it, Pat?
CT abdomen and pelvis with contrast.
Okay.
Nothing fancy. No, my PSA is up probably the last time it was checked, it was 11.72, up from 10.0 3 weeks before that, and probably hovering around 20 right now. So they've got plenty of targets. Anyway, this is their impression. Metastatic prostate cancer with disease progression in large sites of local recurrence with two pelvic masses in prostatectomy bed with similar invasion into the bladder and rectal sphygmoid. Two enlarging metastatic retroperitoneal and pelvic
Can you
lymphodectomy.
summarize for us, Pat? It's hard. It's very
I've got
hard for us to take it in. Summarize for us what it says.
Okay, I've got bone damage, um, on the L2, L3 actually. And anyway, so I'm going to be talking to the doctor in about 10 days uh, and see what other um, treatment plan he can put me on. Since the
Have
first of
you
the year, my PSA has gone from 4.78 to 11.72, and all the metastases from December have enlarged for the most part in the last 4 months.
have you
And
had Pat? Have you had chemotherapy in the past?
I'm I'm on docetaxel right now.
Oh, you're on it
Um,
now. Oh.
I started dosi. I had a little bit of immunotherapy at the end of last year, Keytruda, for about 2 months, and my PSA was spiking on that, so they switched me to dosi and a steady drug, um, capaversitib, and my PSA has gone up, like I say, from uh, 4.74 in December 20th to 11.72
You still on the
on 3/17.
capacitive study?
Huh?
Are you still on the capacitive study?
Yeah,
Yeah.
yeah.
Okay.
I've got one more. I'm five doses into the dosi out of six, and
Hmm.
they've got me scheduled for seventh and eighth. But if it's not doing any good, I'd like to switch stuff.
Hmm.
So, what does Dr. Schweitzer say about it? You see Dr. Schweitzer, correct?
I do. I haven't. I see him periodically when he's changing my meds, and so I'll see him on 428,
So
about 10
I
days.
think, what you got to do, and I'm assuming Dr. Schweitzer is not part of the study. He's outside of the clinical trial. Is that right?
I don't know how to read it actually. He's got a nurse or he's got another doctor that is part of the study. So he is not directly part of the study, even though he recommended me and he's watching my progress in it.
Okay.
Um,
So I think what you've got to do is this. I mean, it sounds like he recommended the study, that the study's being done in, through Hutch, Seattle Cancer Care, et cetera, et
yes,
cetera. But
yes,
he should be independent, and the sooner you talk to him the better. I wouldn't even wait for another uh well, get a virtual conversation going. I mean, why wait another 11 days? He should be telling you right now, green light or red light. And if red light, what are we going to do next? He's your quarterback. And what concerns me is that you're in this capaversitive study, but you've seen no benefit from it.
you're
And
correct.
and and the windows are short. The windows are short. And one of the and we look, we just learned this with Herbie, good rest his soul, that what probably happened probably is that he's cancer morphed. It became neoendocrine. We didn't realize that until Ben did his research, and then we knew what was going on. And the window to treat that neuroendocrine is short. Now, if your cancer isn't responding, then let's try and figure out, maybe the conversation, in my view, with Dr. Schweitzer is, do you think I could have neuroendocrine cancer? If I do have neuroendocrine cancer, what are we going to do? And he's going to say, well, I don't know. And you're going to say, well, maybe we need to do some biopsies and look under the under the slide. And if he says we don't need to do that, you say, well, what are we going to do? But you know very well that here in this group, we say you are your own best advocate. And you cannot stay the course in a trial that isn't producing results for you. You've got to push both the trial doctors and your own GU medonc, who should be independent, and say, what's going on?
I agree. I'll get him after I get done here. I'm going to email him and push on it because, like you say, I really don't care to wait. Almost all the metastases that they measured in December have grown by 30%
Right.
in 3 months, 4 months.
Right. I think one thing to say to Dr. Schweitzer, and he's very good, and you have a good relationship with him.
I
He
do.
knows you. So one of the things is, Dr. Schweitzer, I want to verify right now. You say to me, we just lost a guy whose disease turned into small cell neuroendocrine very, very quickly. I want to make sure my disease is not neuroendocrine, is not small cell neuroendocrine like. It's usually the expression is small cell neuroendocrine like, only because when you talk about small cell neuroendocrine like, it means it's not actually neuroendocrine, although in Herb's case, there may have been some true neuroendocrine. We don't know. But this is what you got to push for. I see right next to you on the screen, Les, we were calling out before for people who go to Mayo to find out how they pay. I don't know, maybe you didn't hear us, but well, if we've got time, we'll come back to you and find out how you get your Mayo paid, because you've done more with Mayo than anybody else. And maybe reach out to Mark K just put his email in the chat window. Maybe you can reach out to him and talk to him about how you get your Mayo care paid for as on Medicare. I'm sorry to digress like that, Pat, but I was looking for
That's
Les
okay.
before
I
and we
got what
didn't
I
see
needed.
him.
I needed a kick in the pants to email my doctor, and I'll do that
Right,
as soon as I leave.
right. And you
Oh,
know
and
I'm good at giving kicks in the pants.
I
Anyone
I
else want to
appreciate it.
anyone else want to say anything to Pat on this capaversitib study? Peter's smiling, Peter K. Peter, what are you thinking?
You froze.
Oh, he froze. He froze.
He could be on placebo. Who knows? Pat, I'm really glad we got to you.
No, I'm not on a placebo. I've got a 90% probability given the side effects. They they put me on it for a week. I had such severe side effects, they took me off. My side effects cleared up. So doc gives me an 80% chance. I've got a 90%. I give myself a 90% chance. It's not a placebo.
So we know it's
I'm
just
on
not
it for
working.
4 days, off for 3. I can
Yeah,
track my side effects. I've been tracking it for 4 months now. Not
no
a
doubt about
placebo.
it then. No
When,
doubt about it.
when was the last time? When was the last time your cancer was sequenced?
Um, when I had my prostatectomy, and um, I don't know that they've ever called it stage 4, even though I've got Mets up and down my spine, on top of my adrenal glands. Um, I don't know that they've
Have
ever.
they ever had your cancer analyzed genomically, sent it to Foundation
Yes,
Medicine or Tempus? When was the
yes, they
last
have.
time that happened?
That was probably 4 years ago, and
Okay,
it came
you've
back that
got
I am MSI high.
right.
That's why they put me on Keytruda, and it
So,
didn't work for
so,
me.
so let me be even more specific for you when you write to Dr. Schweitzer.
Yes.
You ask Dr. You don't ask Dr. Schweitzer. You tell Dr. Schweitzer you would like to be sequenced. You would like to be genomically sequenced. Okay, and preferably from a solid tumor site so that it can be looked at under a microscope and just make sure that your disease is not morphing into small cell. So that way we
Okay.
kill two birds with one stone. They'll find a site that they can biopsy. We can send it away to Dr. Epstein. We can get a good reading of where your disease is at morphologically, and we'll get an update on the somatic sequencing and find out what the best treatment is for you. And we need to do that very, very quickly.
Okay. I'll put that in the email I'm sending out tonight.
And Pat, I mean, we're really sorry. I mean, you're going through hell for a number of years now. It's not fun. I mean, just watching you go through Keytruda and now chemo, and it's a tough one. I know, and you don't know what's going on.
I'm going
So
to push on to Al Latimer next. Okay, guys, I know we'd like to say a lot of things to Pat, but I just got to move. Go ahead, Al.
Hi, John.
Hi.
Last time I talked, I'd had 7 chemo treatments, and the most recent one, the PSA hadn't gone down very much, and I was contemplating maybe taking a holiday because I was getting more and more side effects, and the neuropathy was getting worse. But my PSA went down. Then I found out my PSA went down another 30% on the 7th treatment. So yeah, a week ago tomorrow, I had another treatment. My PSA is down to, it went from 12 to 9, um, which was like a 30% decrease. So I decided to go ahead and have one more. The doctors think I should stop now that I've probably got to the point where the risk of the side effects is going to outweigh the benefits. So, but we'll see. We'll see what this next PSA does. I mean, if it continues to come down, I've had 8 treatments now.
About the neuropathy.
Neuropathy is definitely worse, although I'm not having any physical discomfort from it, or it's not affecting my ability to walk or do anything I normally do. So anyway, that's kind of where I stand. And oh, by the way, next week I'm having another PSMA PET test too. So we'll see where the tumors are.
Good.
And that's my little update.
Good
Yeah,
update.
you were going to talk about getting a somatic test too, from my last lot of notes, Al.
I've had several of those already.
When was the last time?
At MD Anderson in May of 2 years ago right now.
Right. So
You think I should do it again?
I was going to say this when I was just before talking to Pat, that cancer changes. It responds to the treatment that you're on. And your germline mutations are never going to change. I shouldn't say that. We've seen some very strange things happen with germline, but by and large, the germline mutations are in every cell and they change very little. However, your somatic mutations that you make in your own body in response to the treatments, that changes. And so we like to see you get a somatic test, especially if you're in intense treatment, every 18 months or so, every year or 18 months. And Medicare pays for it. When these tests were first approved, it was once in a lifetime. And we went back to Medicare. We wrote and we said, you can't do this. Prostate cancer changes. You've got to allow. And they said, okay, if the doctor thinks it's necessary, get it done. And what I'm saying is to you, you need, and you might be able to do it just with a liquid test. You don't necessarily need a solid tumor test like I think Pat does, but that's up to your doctor to decide. I mean, let Belusic decide how he wants to do it. But yeah, I definitely would ask.
Okay. I actually think I had a test done at UM last year, but it was before I started the chemo. So I guess you're saying the chemo might be changing the cancer, or it might just be changing anyway, just because I've been doing this 27 and a half years.
We know.
Tumor for you. What did they do?
What's the wife saying?
She wants to know where my solid tumor is. It's the last one. The last one was done at MD Anderson 2 years ago.
No, you had one taken out of your neck. Where did that
That's
go?
MD Anderson.
Is that at MD Anderson?
Yeah, 2 years ago.
Okay, I didn't know it was that long.
Yeah, so I had so the PSMA PET showed a met in a lymph node in my neck, and MD Anderson biopsied it, and they didn't come up with anything from it. That was 2 years ago. There was nothing came out of that was particularly useful.
I'd say, and maybe it'll happen again, but maybe it won't. And maybe we get something. Maybe you're MSI high this time. Things, as Peter Kafka will tell you, things change all the time. And so that the only way we can stay on top of it is by doing the tests. The tests are about information. They're not about the treatment unless they
Right.
indicate a treatment.
Right.
So that's what I would say. So how many of these docetaxel have you done now, did you say?
I've done 8.
You've done 8.
Eighth one was last Monday.
Okay.
Last Tuesday, sorry, week ago tomorrow.
Well, all I can say is if you've got neuropathy, but it's not troubling you, you're a lucky guy.
Well, I've heard what you say about that, and I want to stay lucky. I don't want to have pain all the time. I don't have any
I
pain
gotta
right
tell you,
now.
my heels were killing me so much at the weekend when I was in my boat on the lake. I finished up cutting my workout short a little bit because I'd had enough, from this neuropathy that I get in my heels. It was driving me nuts.
So Rick,
you're a lucky man.
It is not in my heels at all. It's just in my toes. And
That's more typical.
So I don't know what to tell you. But the good news is it hasn't touched my fingers at all. My hands are fine.
And you got a full head of hair, and that's what we
and
like.
No, it's not full. I do have some hair. It's weird hair, but it's still there.
It looks good to us. You look great in that picture. You look great in that picture.
You want to see the dandruff?
David Muslin. I don't know what it was. I tell you, you got more hair than Muslin and Emo.
Well, I used to have a lot of hair, and now it's still there, I guess. Enough of it that you can't tell, but so anyway,
you're looking good.
I'm gonna move on, guys.
All right, thank you, Rick.
Tony, are you there? Can you unmute yourself, Tony, if you're there?
Yes.
There he is.
What's
on your mind?
My Firmagon injection last week, and according to Dr. Van and to the radiation oncologist, they feel that would be the last one. I've had 7 of them, and I'm halfway through my radiation, full pelvic girdle radiation. So all is going well, except that also to add that they've been monitoring my AFib and my pacemaker, and I haven't been having any more AFib issues being on the Firmagon in the last 3 weeks. So it seems to be leveling out. But I have been having a lot of problems with my right hip. Ever since I started Firmagon, I've been having a lot of pain in it. And it's getting to the point of every time I have a Firmagon injection, I have difficulty walking for about a week. And I've been to an orthopedic surgeon, and he said it's osteoarthritis. But I talked to this radiation oncologist today, and he has seen it in many cases with women that have been on hormone injections where it does bring a lot of inflammation into the joints. And prior to that, I talked to Dr. Van and another doctor, and they said it couldn't have been caused by the Firmagon. But I just feel, I know my body, that that's what's been causing the pain in my hip. So I'm glad that this last injection of Firmagon is over with now, and we're going to be continuing to check the blood work over the next couple of months. So should be through with the radiation May 15th, and looking forward to having good reports of a good solid remission.
Great.
Is your PSA still not measurable, Tony?
No, it isn't, and the testosterone is down one thing that surprised me, I wasn't thinking about it or aware of it, but being on the Firmagon, a lot of my blood work, the numbers have been dropping down. But then when I started radiation, the hemocrat and the red and white blood cells all dropped down, the platelets, but they're monitoring that, and it's still within a good level. But I've had 7 Firmagon injections, and both doctors have looked at other studies, and they feel that that is sufficient at this time.
Okay.
Yeah,
So you're good.
it's. Go ahead, John.
I was just going to say, so that clears the slate, right? You're going to go uh, on a drug-free period of time now?
Yes,
Yeah, good. What were
and
you going
that
to say,
So,
Rick?
will further indicate whether the problem with my hip is Firmagon related or not.
Right.
And also, I'm glad that I'm not getting any more AFib issues that my pacemaker's been picking up.
Yeah.
so how long will you have been on the Firmagon in total when this wears off? 7 months?
I just
8
had the
months.
7th injection, so it'll be uh, roughly 8 months.
8 months. So here's the issue. So this study came out, which Len will be able to name. I can never remember the studies, but the study was that with salvage radiation, 6 months of hormone therapy is sufficient. And that's what a lot of the doctors are following now in the interest of doing no harm. In the past, the length of hormone therapy that was given, and some doctors still do this, related to the aggressiveness of your disease. So if they came back and they gave you salvage therapy or early salvage or salvage therapy and you were a 3+4, they give you 3 to 4 months. If you were a 4+3, they'd give you 6 to 9 months. And if you were anything higher than an 8 or higher, they'd go longer, somewhere between usually 18 months and 28 months. Okay. And they saw very good results on that. But now a lot of the docs have reverted to this shorter 6 to 8 month period. That is the discussion really that you have to have with your doc, because I think there's enough evidence that yes, maybe 6 months work, but there's also enough evidence that what was your original? You were a 4+5, right?
Yes.
I mean, if it were me, again, not medical advice, if it were me, I'd be staying on the hormone therapy longer than 8 months with a 4+5. It's worth I know, John, you've got to move on, but this is an important issue. And Len, what's your thoughts on this one?
Totally agree with you, Rick. For Gleason 9, up until recently, the standard used to be at least 18 months, Tony. I don't know if that's changed. I'm not aware that it has. And by the way, those Firmagon shots really suck. Believe me, I've had plenty of them. I would switch to, if you have to or decide to go back on hormone therapy, switch from Firmagon to the Orgovix, the pills, so you don't have to worry about that injection site pain and swelling. Maybe that'll improve your hip condition. I don't know.
I was concerned about going off of it at this time because my Decipher and Prolaris scores were 1, plus I have a CHEK2 gene mutation. And so I am concerned about any metastasis going forward. So I've been somewhat in favor of continuing on it, but the 2 docs kind of felt that the recent studies are indicating, as Rick said, that at 6 months.
NCCN, I don't know if they've updated their guidelines to reflect some of this 6 months business, but they used to say something like 18 to 36 or
Yeah.
24 to 36, something like
Yeah.
that. And I think you've got to go back to Dr. V and Dr. Van der V and say, yeah, we know what it says, but that's one study. And I was a 4+5, and I would feel more comfortable staying on for a little longer if that's how you feel. And if I do, I'd like to switch to Orgovix and take the pill form and see what he says.
Okay.
I mean, it's a discussion you and he have to have, but they're so keyed into doing no damage or getting worried that somebody's going to sue them because they kept them on hormone therapy too long, that my concern is that they don't they take men off early, and then we see them back here and we say, how much did you do? Well, I did 6-8 months. Well, what were you? I was a 4+5. Oh, well, maybe they should have kept you on a little longer. And, do we have the studies? I mean, Ben's not here right now. And of course, Professor Herb ain't here to be checking them out. But the studies are out there for the longer period of time. Go to Alan Edell's site. Let me put it in for you in the chat window. Go to Alan Edell's site and pull up all the stuff that's there on salvage radiation. And it's a very controversial subject. There's no black and white answer that 6 months is long enough. There's no black and white answer that 18 months is long enough. Some people do 18, some people do longer than 18. But my feeling, if it were me, God forbid my disease was there, I'd do at least 18 months of hormone therapy.
What are the downside of being on a drug-free holiday for, say, 6 months to see what the PSA does?
Downside is that the disease gets more of a hold, and you have to go back on, and then you have to stay on for longer. Okay. So instead of nailing it right now, you give it more time to grow, and then it'll come back, and then they'll put you back on. And they put you back on, they should probably that will be for a longer period of time. You've already done 6 months, or 8 months. You don't have that much more to do, and we're here to support you. We're here to support you anyway. But I don't know. Anybody on the group face this decision? Is there anyone else that can relate to this, that can talk as a peer to Tony?
Rick, I had this discussion with Dr. Gainesman, and he was very insistent that 6 months was sufficient, and he kept harping on, Alan, the hormone therapy does not kill the cancer; it only weakens the cancer, and there's no sense in you being on that longer than you have to be on it, because you'll be on it. We'll weaken it with the Orgovix, and we'll zap it with the radiation, and that's what you need right now. And I talked to him, and he was he was very insistent. No, we're not doing that. It's not in your best interest.
Okay.
Well, that's just another side. It is. It's not clear. No, it's funny. He didn't tell me it wasn't clear, but that tends to be his style. Anyway, I had that conversation, and it didn't go anywhere.
All right, thank you very much for your input, and I'll have a discussion with Dr. Van.
Okay, and I'm putting Alan's website into the chat window for you right now, and go on there because he has all the studies, including this latest. I forget the name of this latest 6-month is sufficient study. Do you remember the name of that study, Len?
No, I don't, Rick. But I was going to say the same thing you did. Alan Edell recently did a pretty thorough write-up on length of ADT following radiation therapy. So that's the best place for Tony to go.
All right, thank you, everyone.
Yeah.
Frank, quickly, if you have something.
Sure. If you remember, my PSA was climbing, not in large numbers, but in 3 months it went from 0.8 to 1.2, and I was scheduled for my CT scans, which was this past Tuesday. I had those, and in addition, they did a blood draw, and surprisingly, in the blood draw, the PSA went from 1.4 to 1.2. I have another blood draw tomorrow when I see my oncologist, my doc, and we'll see where it is there. I had a CT abdomen pelvis with contrast, and I had a CT chest with contrast, the two CT exams. The first one on the abdomen and pelvis, I've had two nodules on my pancreas that were seen in 2016. But each year that I've had the CT scan, they've remained stable, and they remain stable with the latest CT scan. So the doc there said, don't worry, we'll keep checking it once a year. On my chest scan, I was pleasantly surprised with my 3 nodules in my lungs that 2 of the nodules decreased almost half the size. 1 nodule disappeared, but a 4th new nodule appeared, and it's about 1 centimeter by 1 centimeter. So tomorrow, with my discussion with my doc, I need to find out what will be the options with that, and also see where the blood draw and the PSA is. So I was pleasantly surprised, and hopefully it'll be good news tomorrow. That's all my news.
Any discussion?
Yeah, Pat, when you do your blood work, do you check the pancreatic numbers?
It's
Does the
Frank.
doctor order that?
It's you talking to Frank or you talking to Pat?
Frank. Sorry, I'm calling Frank.
The pancreatic numbers, which would be what, Peter?
Well,
Amylase and lipase.
Yeah, amylase and whatever the other one is. Yeah.
I haven't specifically looked at those, and my doc hasn't mentioned them.
Yeah.
But I will bring that up tomorrow.
Yeah, I don't know if it relates or I mean when you're talking about spots on your pancreas, it just rings bells because I have to monitor mine pretty carefully every 3 weeks.
Yeah, they discovered mine in 2016 when I was diagnosed with prostate cancer, and I had a second opinion and from a radiation oncologist, and that's when they discovered the 2 nodules on the pancreas. So they've been watching that once a year, and they've been in each year they've been stable and haven't grown, haven't shrunk in size.
Yeah, I have no nodules, but the treatment I'm on affects my pancreas, and and when I do my blood work, it goes wonky every time.
Mm-hmm.
Rick,
But I'll mention it to my doc tomorrow.
Rick, I still have quite a few guys, and it's 10 o'clock. Should we ask them to hold off until next Tuesday, or go on?
I'm happy to stay as long as it takes, John. But the other mods feel free, but we'll keep going.
I've got Jack next.
I'll be brief. I just want to give a summary of what transpired this past week. I went up to Sloan Kettering for the day on Wednesday, and being that I've been on darolutamide for 5 days prior to going up, they did a PSA, and it went from 2.01, pretty similar to the lab down here, to 1.14 for whatever it's worth. And my
Yeah.
testosterone went from about 588 to 733. So I'm trying to understand that from an academic point of view, because I know the receptors are blocked. Does that mean that the testosterone level is going to get higher when you take darolutamide? And I'm only taking 300 twice a day, and I'm not taking ADT primary drug. David, I know you've been taking solo darolutamide. Did you notice your testosterone went up?
Sure did. Mine is 700, 800.
Oh, so that does happen. So the PSA went down, the testosterone goes up. So he suggested I go on Degarelix, and he said, if you're so concerned about Relugolix, and I said, oh, all right, I'll check it out. And I went home and I checked it out, and it's so no difference as far as how it
Well,
mixed.
you're right. What's the
What?
difference?
That's what
Yeah,
I said.
what's the difference? I mean, it's like hello, maybe we
I don't know. He gave him
yeah,
justified the visit.
hello.
He justified the visit with that suggestion. I said it's ridiculous. So I'm not going to do that either until I get my ablation. The other thing is he wanted to do I can't get another foundation. You said 18 months they allow Medicare? Because Belusic told me you can't. I had a foundation, one done liquid biopsy a couple of months ago. And I said, oh, well, if we can do it now that we have tissue, can we get it done again? He said, no, no, no. Medicare will never pay. It'll be $5,000 out of pocket. But but Sloan Kettering wanted to have a piece of tissue, and I know you would advise me not to go through Sloan Kettering for whatever reason. But they said they would do it, and it wouldn't be costly in any
No,
sense.
Belusic, with the greatest respect, that's not right. I mean, we've known guys get them 6 months or even less apart. If
Is that
he
right?
feels that there is reason, there has to be medical reason. So if he feels there's medical reason, you can get it. But if he's not willing to say there's medical reason, it's as they say in the classics, Jack, ochim vey.
I
You
got
got
it.
no chance. Okay?
So let me tell you, Sloan Kettering's reason was that, mutations, in spite of the fact 20 years later, now I have a metastatic lesion in my lung. He said, it can cause a mutation even though you've had no treatment besides a
Right,
prostatectomy. So with that in mind, he said he can then justify why he would want
right,
to get either foundation or something. The other
right. So you
thing is,
go back to Dr. Mario and say, Dr. Mario, look, I really would like you to suggest that we need another one. And either do it with liquid or do it with solid, what he thinks best. But you got to lean on him. It's he's not right about the 18 months.
okay, I thought, all right, good. I'll go back to them.
Okay. It is now based on doctors' need, and we've seen these as close as 4 months apart with people that have very, very fast moving disease. There may be even some people on this call that have gotten them that close apart. But by and large, if it's more than a year, nobody's giving you a hard time.
It's only a few months. Now, he told me something else about the MRI. He wants to get a baseline MRI of my spine with a metastatic lesion at L4 pedicle. I said, why is that? He said, because he said he notices after treatment, whether it's through hormonal treatment or radiation, spot radiation, that there's sort of a flare of inflammation following that around the lesion, the metastatic bone lesion, and he wants to get a baseline because it's often mistaken for a recurrence or a progression rather than a healing effect. Did you ever hear of that?
Yep. Yeah, I
Yeah.
mean, we do see a flare on treatment, but not usually on just plain hormone therapy. It usually is a response to chemotherapy or can be from radiation therapy or from immunotherapy. Yes, I mean, we do see it. A flare from just going on hormone therapy,
I
No.
don't know. I defer. I'll
Okay.
defer to Peter. You want to say something?
No, no, I don't. I don't know. I've never had that experience.
This was all new to me. And then he questioned the SBRT at the L4 pedicle. He's concerned about bone marrow depletion, and he recommends ADT all the way, shrink it down, put it to sleep, rather than the SPRT spot therapy on the body or any other part of the vertebrae. Are you all ever concerned about bone marrow depletion of with that
Well,
kind of?
you know, we're not docs. Go ahead, John. Why don't you answer that one? Because you're a doc, so you can say more than we can say.
Well, he talks to me like a fellow doc, doesn't he? John?
I didn't know that spot radiation, SVRT, which aims at such a very small area of bone marrow, I didn't know that it could have a wide enough
That's
uh,
exactly what I said.
effect. I mean, maybe the radiation spreads through the marrow and that becomes a factor, but I had not heard that radiating such a very tiny area could
Uh, he,
cause quote unquote bone depletion.
the radiation oncologist said he would do more than just the pedicle because he's assuming there's more within the
Oh,
body and elsewhere. So I guess he would do a more diffuse, beam of radiation on that L4 vertebrae. So
well,
that's
then
what I.
it sounds more possible to me. I
Yeah.
don't know.
That's all I have to say. Thanks, guys.
Jim Barnes, you had your hand up. Jim Barnes has a raised hand.
Sorry about that.
Okay, you didn't want to say anything.
I,
Is this our friend Danila?
Yes.
Well, as I've told you before, I spent 5 years in Bucharest, so I have my own opinions.
Right.
Okay,
Right.
it didn't come from a 2 week holiday living in Romania either. Okay, so and you might want to talk to Len, who the best thing that Danila did for Len was drive him to Dr. O.
Well,
That's
let
true.
me tell you what he said. You're not going to be able to utilize me any longer unless you have a mandatory visit. So I flew up for the day to New York just so that I can continue an occasional telehealth or a reread on my scans, or God forbid I should get into serious trouble and get into a study. So that's the reason I flew up for the day, because Danila said it's either that you do it or no more. So you're right
Look,
about that.
I'm
Autocrats.
gonna
you
I'm
know,
I'm gonna move down the list, guys.
I just want to say one thing here, Dr.
Yeah.
John, and I know we're late, but I think it's important. We, over the years, we form opinions on docs, and we're not shy to voice those opinions. And nobody's ever come back to us, ever. Why? Because we form them on the basis of experience with those doctors, anecdotal experience with those doctors. And the last few days, the last 2 weeks really, I have been beating myself up because I never, ever was able to convince
NIH.
Herb's doctor, not at NIH, at Hopkins, Herb to leave his doctor, who we never liked. We never liked for a bunch of reasons. And why? Because this guy was smart enough to give Herb the time that he didn't give to other people. And I never trusted him. And I got to tell you something. Herb's doctor got duped by Herb's back. And he never went further. When he saw those numbers back in January for Herb, and there were neuroendocrine numbers that were high He didn't follow up, and he should have followed up, and he didn't follow up because he put it down to Herb's back, and what was going on in Herb's back was cancer and not arthritis. And what I'm saying is, you just got to trust us. When we give you an opinion on a doc and we say we love this one, but we don't love that one, it's not just coming off the top of our head. It's really not. And I know this is being recorded, and I'm happy to talk about Herb's doc at other times. He's got a patient who's in the group right now, but he ain't my favorite. And the same thing with Danila. He's not our favorite.
I get it.
But we do like Belusic.
I
And you
like it.
tell him, and you
Okay.
can tell him.
I told
You
him.
can tell him. The guys are on the Foundation Medicine Community Council, and they feel very comfortable that you can do it more often, and we'll work with you. If they come with you with a big bill, which they won't, we'll help you.
And he's very accessible. He communicates. He gets right back to you. Great connection, Belusic. I thank
Okay.
you. Yeah.
Okay.
enough
Go
said.
ahead, John. Sorry, I had to say that.
Thank you.
David Muslin.
Okay, this will be a little helpful for Tony Fig. Just want to give you a little bit of history. I was on Lupron for 22 months with 3 second-line drugs starting in February of 20. I went undetectable in December of 20. I was on Lupron for about 22 months. I ended it on December 21st. And then I went on single dose or mono darolutamide in April of 22, which was a year ago, and had only two side effects. One was hot flashes. The other one was gynecomastia. Spoke to Dr. Schmulowitz on Friday, and he loved the story, stay the course. And FYI, he has one other patient on monodarolutamide, just like me, pretty much the same numbers, high testosterone, 7 and 900, undetectable, also gynecomastia, and also hot flashes. And the treatment plan for me going forward is stay the course on darolutamide for probably at least another year, and we'll see how it goes this next year. But right now, things are looking up. So that's the follow-up from Dr. Schmulowitz and darolutamide after being on it for a year.
Can I
Could
ask
you,
you a question? Can I ask you a
yeah,
question?
could you repeat that second side effect? What is that?
Gynecomastia is enlargements of the breasts.
Okay, thank you.
So what I did for that is I didn't start it right away. The group suggested maybe getting radiation for that. I didn't do that. They started getting big. I got on 20 milligrams of tamoxifen, which I'm still on, and my breasts haven't grown anymore. Talked to Al Latimer about that a couple weeks ago.
David, let me ask you a question. Why aren't you taking Relugolix or something like that?
Because what I've learned here is after 2 years, it's a pretty good time to get off the Lupron. And so I was on it for 22 months. Everything was working, and it was time for a change. And darolutamide is working great, and I've been undetectable since December of 21 now.
Interesting. Does it decrease your chances of becoming castration resistant by staying off the Ornavix, the Relugolix, and just doing second line?
We don't know. And what I've learned is you want to change it up after 2 years. And a stat that comes out of Schmulowitz's mouth is it's about an average of 3 years before you go from sensitive to resistant.
I would assume not, because the androgen receptors in the prostate cancer cells are not seeing testosterone either way. Therefore, they're adapting to that.
Right.
So I wouldn't plan on it being safer.
Okay.
Joel?
So for right now, that's the story. So I'm doing okay. That's the update, Len.
Okay.
Yes, a quick update, Dr. John. Saw Dr. E on 4 April. My PSA from the previous month went down from 0.07 to 0.05. My testosterone is 6. She said she was pleased with my progress. And I told her about my issue with loss of sleep, getting up 9, 10 times a night to urinate. Says you have anxiety. I'm going to put you on a sleeping pill, and she prescribed for me. I haven't gotten it yet. And I'm also, because I saw a cardiologist oncologist about 6 months ago. I'm taking a echo tomorrow and a Lexus scan, which I understand is a 4-hour test within the next 2 weeks. Dr. E wants me to be on a weight loss medicine. She was going to prescribe in about 4 months from now a Wigibo, and which is the cost $1,000 a month that I have to pay for. I said, well, how long am I going to have to be on it? She says 2 months. And actually, she said 6 weeks, but it's going to cost me a couple of $1,000s out of pocket. I said, okay, I could probably do that. And so she says basically the drug, all the drug does is make you not want to eat. You're not anymore, so you don't eat as much. And she says she put her husband on it, and it's worked fine for him. So that's where I am with Dr. E. PSA 0.05. So hopefully in the next couple of months, it'll be down to less than 0.01.
How much exercise are you doing, General?
Well, I went to Miami for 4 months thinking that I would lose at least 10 pounds. And I was going great. I was, for about a month, I was doing um, um, 5 to 7 miles a day, about 15,000 steps. Then I got COVID, and the state of Florida called me up and said, "You stay home. You don't leave your condo unless you're going out for some medical help." And so talked to my primary care doctor and so on, and they said, "Okay, we'll seek some local help in Miami." Went to the emergency room at Mount Sinai, and they said, "Okay, you're doing good. You already had 5 vaccines, so your COVID is very light, but I'm going to take a picture of your lungs." They took a picture of my lungs, and they said no COVID or pneumonia in the lungs. They sent me home. But basically, I was without exercise for 3, 4 weeks, and so when I came back from Florida shortly thereafter, I came back at the same weight that I had left, even though I had lost some weight when I was doing a lot more exercise. So anyway, again, I'm planning to go back on more exercise, but that's I'm not doing any exercise the last week or so. I've been busy filing taxes, and so that's hardly any exercise at all, except for mental and exercising my seat, basically.
Well, you know what
Joe,
we got to say. Listen, the last week, I've been running Ancan. We've lost Herb. I'm working on Pluvicto, and I filed my taxes, and I still managed to get in 3 sessions instead of 7. I get it because I couldn't do the exercise I want to do, but it's a priority.
Yeah, I
It's a
agree with you. Yeah,
priority. Okay?
yeah, I agree.
Joel, what was the drug you said Dr. E put you on?
It's a
I
drug
didn't.
that Moyad, Dr. Moyad pushes. Wegovy, Wegovy, and there's another name to it too. And there's
Oh,
a
I
couple
know
of
what
drugs
that
that
is.
they.
Oh, yeah, that's the
That's
weight loss drug.
semaglutide.
Yeah.
That's
Yeah.
semaglutide. It's a glucagon-like receptor agonist.
Yeah.
Hey,
Yeah,
Joel.
yeah, go ahead.
Joel, this is just Joe Gallo. The VA
Yeah.
pays for Saxenda for me, which is the same family.
Oh, good point. Good point. Thank you for telling me.
Cost me nothing.
That's fantastic. I better hurry up, and that's another thing I got to do. I got to visit the VA and get a bunch of things done with them.
Yeah, just call your
Okay.
primary. It's a
Okay.
if you They're the two different ways. The Saxenda is a daily injection. The other one is a weekly, but it's not a big deal.
Okay. All right. Very good. Appreciate the comment.
I'm going to move on to Todd. Sorry for the long wait. What you got on your mind? Still muted, Todd.
There I am. Hello.
Hi, gotcha.
Had the pleasure of having lunch with Len today, so that was really nice, and we
Oh,
talked for a while about different things. I'm a little freaked out about all the different terminology. Holy cow! I keep hearing all these big words, and it's very intimidating. But so my PSA is going up, a lot more than I'd like for it to be going right now. It just jumped up to 7.7 from 5.8 in the last 3 weeks. Um, but as you know, Rick and Len, I did give with and David, I got with Dr. Schmulwitz. So I'm hooked in with him, which is great. And I'm actually going back to University of Chicago next Thursday from down here in Florida for a bone scan and some other things. So, and I'll be starting on the Orgovix and the Zytiga as soon as I get those pills, which should be this week. And that's where I sit.
everybody happy
Well,
with that? Any comments?
Todd is going to be seeing Dr. Guancho on Thursday, April 20, same day I'm going to be there. We may bump into each other again.
Yeah. Yeah. Looking forward to having hopefully a person down here that I can work with as well as up there.
So you're going to do Orgovix and did you say darolutamide?
Zytiga, which is
Zytiga.
Yeah, Zytiga.
Right.
Yeah.
Okay, so I guess what I was going to say is it's needed because with the PSA jump to 7.7, sooner rather than later, we will work with you when you start on the hormone therapy. Certainly Len will. He's right there. He has great experience. Everybody responds differently, so we don't know how you're going to respond, but the chances are something will happen. So we're here for you, and we just want to see you start that therapy.
Thank you. So do I.
Orgovix has been mentioned a few times. Are there any programs available to help with the cost of that? Because I understand it's about $1,600 or $1,700 a month.
Oh, anybody?
The list is more than that, in fact.
Yeah.
But I don't have the connection for it, but there was an organization in Florida, and if I can look it up, I'll find it. That covered what Medicare didn't cover. Medicare does cover it at an 80% rate, but it was $4,200 that they had to pay.
I was able to get a grant from the Patient Assistance Foundation. So they were closed early in the year. I was on the waiting list, and now it's opened up. You might want to check that out. But also, your oncologist can fax the information in to Orgovix, Myovant, and they do have a patient assistance fund where you might be able to get some help from them.
Yeah, and we haven't done this in a while because to begin with they were pretty lax and they were giving it away like candy, as Peter remembers, Peter Kafka. But I'm making a note to myself, maybe next week. I'll reach out to our contact Myovant and I'll find out what's going on in terms of patient assistance right now, it's a little tricky what they can say, what they can't tell me. But let me see what I can find out, if there are any good sources, and what exactly is going on with their own program. Are they still sending it you through the mail, Peter?
No, I stopped taking it well, a long time ago. It was reacting. It reacts to the Keytruda. No,
That's right.
I stopped taking it a year and a half ago.
But
And
they kept
I have
sending it to you. They kept sending it to you, didn't they?
a little bit, but I passed it on to somebody else. Not much. No,
There
I
you go.
stopped.
Is Richie still on the call?
No, he left
And how
early.
about Joe Commando?
No, he left.
He
Okay.
didn't leave. He's right there. I see him.
Yeah, I'm here. I don't think I really need. It was a curiosity question, and you still have more people, right?
Nope, that's the last.
Well,
You
I'm the
can.
last one. Okay, well, I talked to oh my, now my mind is going blank. A not genealogy,
Geneticist.
a counselor. I think that's what they called her.
Right.
And I'm scheduled to have a meeting over the phone in a couple weeks. And I was just curious if you had anything you thought I ought to ask.
Anyone?
Are they done testing on you already? Is that what
No,
it's
none.
follow up?
No.
No.
This is I guess they're gonna ask me lots of questions, and then eventually, following on that, they will test me.
They're going to
Well,
ask
one
you
thing.
about your family history. They're going to ask you about your parents, your brothers, your
Right.
sisters, your aunts and uncles. So just kind of
Right.
make a list of all that beforehand, so you know how to
Right.
answer that.
Okay.
Yeah, I mean, really, what they're doing is they're verifying that you are eligible for the test,
Okay.
for the germline test. Now, there's
Right.
a shortcut to all of this, Joe, if you want to do it. And we may have talked to you about it before, which is the promise test. Have we talked to you
Right.
about the promise test
Yes. Yes.
before?
I looked into that a little bit.
Okay, so if you don't want to go through all of this with the counselor and everything else, all you got to do is apply to the promise test, and they'll send you the kit, and you'll send it back to them. And then if there's anything that shows up, you'll have a session with a genetics counselor.
Okay. So in other words, get the
Okay,
test first.
but you'll get the
Well,
test first.
when
Right.
you sign up for the test, you'll answer a lot of questions online.
Oh, do you? Okay.
Make
So let
sure
me.
you don't say you want your doctor involved. Otherwise, they will not do the spit test and it will be very complex.
What do you mean by not do the spit test?
Well, they send you a spit tube normally, but
Right.
if you say you want your doctor involved, then they have to go through them first.
I
And
see.
so
Okay.
if you just don't say that, then they will just send you the spit test as long as you qualify. Do you have other relatives with cancer, breast cancer, or
Um,
prostate cancer?
yeah, I actually do. I have a cousin who died of prostate cancer,
Right.
and his brothers uh, also have had it and been treated. So I'm kind of 8 years
Yeah.
behind them.
You need to get the test.
Okay.
Yeah, and I'm just 1 second. I'm just looking for the link for you, because we have a link that is here. It is. I got it.
No, I
This is
have
the
it. The
link.
one for promise, I have it.
Well, yeah, this is for us though, because
Oh,
they
okay.
track it back to us. It doesn't make a difference to you, but it's just this is the one. This is the one. I just put it in the chat window that is
Okay.
tagged back to the Ancan group.
Okay.
Okay.
Joe, do you
And
live in
and
Philadelphia itself or outside?
No, I live in the Glenside area.
because there's another guy on our call, Dr. Bob Gramakin, who's lives right in Philadelphia.
Oh, okay.
So you might
Yeah,
want to sometime chat with him next time. He left earlier, but sometime chat with him online.
Okay.
yeah, he left earlier, and then we've got Captain Joe who lives in Bucks County, and Jim
Right.
Jeffries who also lives somewhere around there. Jim was here. Jim's here too. We got a bunch of guys in your area.
Yep, I'm here.
Eagles fans. Eagles fans.
The highest paid quarterback.
I think Babcock's, Alan Babcock's from the same area as well, out here somewhere.
Yeah. Yeah, he's
All
a bit
right,
further west, Babcock.
All right, gentlemen, we've made a marathon tonight.
We have.
I hope we've done right by everybody, and we'll see you next Tuesday, right?
Okay.
Okay.
Good
That's
night,
Len.
everyone.
Good night.
Rick,
Good
I'm up
night.
I'm up Tuesday, right, Rick?
You are. Yes.
All
You're
right, I'll get
you're
an
for
intro to you.
Tuesday. Okay. Good night, everybody. Great job, Dr. John.
Yeah,
Good
great
night.
job, Dr. John's right.